Hello everyone, this is the recording of the Nebraska Federally Qualified Health Center Cancer Screening Initiative, which is part of the curriculum for your CME and maintenance certification credit. This is part of a contract with Department of Health and Human Services, so all of you should have a contract that looks something like this, and we are the contractor that's supposed to help you implement and enact this project. So as a timeline, we're having a site visit with all the clinics in November and December. And starting in December, you'll do the start of the CME and Part 4 Maintenance of Board Certification curriculum, which we'll be talking about as part of this recording today, and also our site visit. We'll have a subsequent visit and review of the data in March, and then we'll be out for another site visit in May or June, where you'll finalize and receive your CME and Part 4 Maintenance Certification credit. There'll be two forms that you'll need to do after this presentation for those who want CME and maintenance certification credit. The first one looks like this, and we'll be talking about what this involves. Second will be a workflow diagram that'll look something along these lines, and that's what we'll be explaining as part of this presentation. So back to the big story, why are we doing this? Well, this is part of a broader effort across the state. 80% by 2018 is actually a national effort to increase the number of people screened for colorectal cancer. And so the genesis of this project actually starts from a lecture by Ali Khan at the end of 2015, where he talked to the County Medical Society in Lancaster County in Lincoln. And a group of us decided we'd try to take on a project to improve cancer screening in Lincoln and see if we could be the first to get to this goal by 2018 in Nebraska. We started this project in 2016, and initially with clinics in Lincoln, Nebraska, but as the project took off, it started involving a few other clinics in Nebraska City, Crete, and Kearney. What you see here is a visual of our clinics that are participating in this project. The pale box circles are where they started in early 2016. The blue circles are their progress in the middle of the year, and they're all right now finalizing the project for 2016. Like I said, the goal is to see if we can move up the cancer screening rates for cancer in Lincoln, and we've so far looked like we're on track. This is actually Health Department district level view based on Medicare claims data of screening rates across the country, and it seems to be working. And this is what got the attention of DHHS, and they asked us if we would consider trying to make this work in the federally qualified health centers across the state. We're also working on breast cancer, so we have similar results for breast cancer screening, and also we would like to incorporate the UDS measure for cervical cancer that all of you are already using. So the project benefits for you are a couple things. Number one and foremost is our goal is to improve the care that you're providing to your patients, and we'd like to help you do that. Second, you'll actually receive funding for this project to help you do that. So depending on your contracts and your performance, you'll be receiving $60,000 to $65,000 to fund care coordination, health education, and quality improvement work in your clinics. You also, for the providers in your clinic, will receive 20 hours of CME credit. This includes nurse practitioners and PAs. And for your physicians, you'll also receive Part 4 Maintenance of Board Certification as part of this project. Side benefits is you'll be able to have, I think, possibly some better comparable data to your peers across Nebraska. We'd like to do some further work this spring on analysis of data by insurance status, race and ethnicity, and language preference to help see if we can find better ways to reach particular populations within the federally qualified health center service areas. And hopefully this data will also serve to guide future state projects. So like I said, this is a CME project, so it does have a curriculum to it. The curriculum starts with DMAIC, which is our model for quality improvement. DMAIC is used in the manufacturing industry, and it's been used in healthcare as well. The DMAIC stands for Define, Measure, Analyze, Improve. And in manufacturing, it's control, but for clinics, I think communicate is actually a better thing to talk about, and I'll explain why here in just a bit. Like I said, it's been used in the healthcare industry before. This is a German hospital study where they used DMAIC as their framework, and they use what I sometimes call the ultimate quality measure, which is dead, not dead, and they made progress on all four measures by using this framework. Our definition again, so D stands for define, and we're defining quality based on the National Quality Forum definitions, and your UDS measures are the same measures. You're already reporting on cervical and colorectal cancer, but we'd also like you to develop the ability to report on breast cancer screening as well. A couple other things on definition. Colorectal cancer screening right now, based on current recommendations, is defined as screening based on any of these measures: colonoscopy every 10 years, FLEX-SIG every 5 years, and fecal occult blood testing or FIT testing. DNA is not currently recommended by the U.S. Preventive Health Services Task Force because it has a higher number of false positives and it's uncertain what the recommended follow-up should be. So we're encouraging to use, if you're going to use these, to use FOBT or the FIT test as opposed to DNA screening. Cervical cancer screening keeps changing. You know, when many of us went through training, it was simple. It was just Pap smear every year. These intervals are changing partly because of HPV vaccinations are actually lowering the incidence. But these are the current recommendations, and either is optional. And again, that's partly your clinical discretion with your patient. For breast cancer screening, there's a bit of controversy. The quality measure we use actually it fits for all three of these. Essentially, as long as you're getting screened every other year, any of the other measures will also work, because if you get screened every year, you're still going to be qualifying under the every other year definition that the USPSTF American Academy of Family Physicians are recommending right now. So adequate screening will actually work any of these. And again, this is up to your own clinical discretion and your own clinic's decision about which of these definitions you want to use. However, when you report quality, you will use that NQF measure mentioned previously. So definition, the start of the project is basically you pull numbers, which is the same as your UDS reports, enter a percentage as far as the numerator denominator for where you are, and then your clinics will set a goal of where you want to be. So for example, if you're starting at 25%, you may choose that our goal by the end of this project is going to be to say 35 or 40%. So we will help and talk with you about how you might set that target based on what your baseline is. We're asking your clinics to pull these measures before our site visit when we drive out to your clinic. Additionally, it's good to generate reports by providers to see kind of how people are doing across the clinic. One thing I always point out, though, is not to take what sometimes is called a rank and spank mentality. You're not there to penalize whoever has the lowest score. Your goal is to find out who's doing better and why. So why is this physician doing better than this physician, for example? Do they have a better process? Do they have a better rooming project? Do they have a better sales pitch to their patients? Also, sometimes people have a lower percentage not because they're doing worse, but simply because of bad data. So sometimes the problem for this low report is that the EHR isn't capturing colonoscopy screening correctly, and so sometimes it's cleaning up the report. So especially initially, don't go to jumping and blaming people, but focus on who's doing the best and why. What could we reproduce across the clinic? Next is to analyze and improve. So once you start thinking about why, what are we going to do to improve it? What things might we add? We have a care coordinator position. Are they going to do some tracking of the patients to find out why they aren't getting screened, do some reminders? Are we going to put alerts in the room or alerts in the chart? Are we going to make sure we do an extra check when we're rooming the patient? Things like that are interventions you might consider. Again, when you're looking at why, this is a good study from Family Practice Management where they were talking about looking at vaccinations within a clinic, and they looked at why patients weren't getting screened. It turned out that some patients had left the practice. If that's the case, you should deactivate that chart. Sometimes patients missed the clinic and they didn't have a reminder to capture them. Sometimes the patient was there and it was a missed opportunity on the part of the practice. So why are people not getting screened? If we can figure out why, that helps us decide how we're going to make a difference and make our screening rates better. Again, and finally, communication. Well, one of the reasons we want to use these workflow diagrams is as a communication tool. Also, we want you meeting as a clinic because that discussion between the providers is actually one of the ways to do your quality improvement. And it's important that this be a team approach where the discussion involves everybody, not just the providers in the clinic. And everyone in the clinic should know the role they play in improving quality improvement. Physicians, nurses, back office, front office, office managers all play a role in quality improvement if a clinic is doing it right. So workflow diagram. So once you've reviewed your data, you're supposed to then try and come up with a plan for how you're going to make your quality improvement better. Some clinics will start by basically just using a whiteboard or even just sticky notes on a piece of paper. This is actually a nice way to actually kind of plan out what your workflow might look like. The goal is to get to a point like this where you've actually got it written down, and the reason for having it written down is this is something that can be distributed amongst the office so everybody knows what the process is, what the plan is. Physician offices are notorious for having a meeting on Tuesday night, but then nobody tells the rest of the clinic on a Wednesday, and then on Thursday people wonder why nothing got done. So by turning it into a written document, you can pass this around, and then of course later on you can modify it and then replace that document so everybody has a clear understanding of what the plan is. One of my favorite examples is this from one of our Lincoln clinics that took this picture of their full project, actually just with one picture. On the right here, you actually have their original quality measures by physician and their final. Here's their discussion at the end of the time where they took their midpoint results in August and how they got much improvement they made until August or in October. Some decisions they made, and then some examples of their workflow diagrams at the end. So here, just in one visual, you can see a year's project and how much it worked. Why don't I give you a workflow diagram to use. The reason is I don't know your staff, what resources you have, and which interventions you pick are up to you. You can't do all the interventions, so you're going to pick what is most feasible in your clinic, because sometimes those interventions are limited by your AHR, for example. Within your contract, there are several listed interventions. For example, you might pick a team huddle. Provider feedback are those bar charts I was showing you earlier. You may have some standing orders where an FOBT can be ordered without even involving the physician. You might involve community health workers. You might create reminder systems within your EHR. You might have some marketing campaigns, and you might do working with other agencies to have synergy. In Lincoln, for example, they're considering working with their ethnic community centers, El Centro de las Americas and the Malone Center, to do some co-branding and marketing so that it's a better way to push out the message. Once you've done that, then you create your workflow based on the staff that you have and the interventions you pick to then achieve your outcome. There's also research showing actually that clinics that come up with their own workflow diagrams do better than when a workflow diagram is foisted upon them. And you know your situations and your resources better than I would anyway, so it's best for you to come up with your own intervention. Again, reviewing the timeline, so you'll create both this baseline measurement and a workflow diagram for December. You'll pull your data again in March, kind of like that visual I showed, and then there will be a final, and we'll come out for another final visit in March. I'll also be available by webinar and phone calls, and we may come out other times if necessary. A few caveats. One thing I'll point out is a lot of projects, when they start these when they pull their data, they start learning that their data actually isn't very good. This is an example from my clinic 11 years ago where we were working on pneumonia vaccinations and found that our numbers on pneumonia vaccinations looked horrible. 20% is not a good measure, but the reason it is so low was actually bad data. We had an EHR, we had paper back here, and we hadn't taken those Pneumovaxes and transferred them to the electronic medical record chart, so our number wasn't right when we first started. We went and reviewed our data, pulled those Pneumovaxes over, and found out that our real number wasn't that bad. We were around 57%. But then by putting in these workflows, standing orders, reminder systems, things like that, we rapidly were able to improve to what then was a very good rate and very competitive nationally. And this was a clinic, it was a residency program that took care of about half of the Medicaid in town and a refugee population. And so if we were able to do that with a clinic like ours, I'm sure you can do it in a clinic like yours. With our project in Lincoln, again, this clinic here wasn't that bad. It just had bad data. When they cleaned up their data, they found out that they actually had really good quality measures. This clinic here, for example, is still working through their bad data. It turned out that not only are our colonoscopies not in the right place of the chart, they've got a problem where they haven't been deactivated patients who died and moved away, and so it looks like they've got a huge patient population when really they're a clinic equivalent in size to this. And so they're still working on some of that cleaning, but the last report they've told me that they have providers in the 60 to 70% range, so they're actually up in here. So a good part of your starting is actually cleaning up your data. So just in summary, we had a talk a few years ago from a physician, a family physician named Mary Ellen Benzik, who works in Michigan. She's worked with dozens of medical home projects like this, and I asked her at the end of her presentation, what's the take-home message? What's the difference between a clinic that does well and a clinic that doesn't do so well? And Mary Ellen's take-home was that physician leadership was key, but kind of nuanced. The physician needs to be present, involved, but they also need to delegate appropriately. Micromanaging actually doesn't help, and you need delegates because a physician's time is limited. And so that cooperative role between the physician and their care coordination and management was huge. The second was measure and keep it simple. Pick a couple measures like these, so cancer screening measures, for example. Do those well, then move on to the next measures in a year or two once you've got this ironed out. Third was that the whole team needs to be involved. Everybody has a role. So for example, the back office, they're the ones sometimes scanning in that colonoscopy report. It's important that they put it in the right place, make sure they enter the date. They can help improve quality improvement as much as everybody else. Last is the team needs to get together like we're going to be doing shortly, where we talk about this plan and how everybody talks about how this is going to work, and having those monthly staff meetings where you talk about your progress on the project. That these four things are the differences between clinics who do it well and the ones who don't. So again, summary of the project, we're using DMAIC as our model, and again, we'll be around to help you work through this. Also later on, if you have other interests, we're also going to be recording some future things like staffing for effective quality improvement, or how to and how not to use data. So we'll see you soon, and hopefully this gives you a better understanding of the project going forward.